Bismillahirrahmanirrahim ji. Okay, so today we have a really interesting case, and I promise you by the end of this video, you're going to question everything you thought you knew about giving oxygen to patient. Let's read the case together. A 68 years old man with COPD presents with 3 days of worsening dyspnea, chest x-ray shows hyperinflated lungs, no consolidation. He started on bronchodilators, steroids, antibiotics, and supplemental oxygen. Of course, that's the treatment for COPD exacerbation, right? The next morning, he's lethargic and confused. The saturation of oxygen is 98% on 3 liters of oxygen. Respiratory rate is 26 per minute, and he has asterixis on examination. There are no focal neurological deficits. His extremities move. Sorry about that. His extremities move equally to painful stimuli. No liver disease. Which of the following investigations is appropriate to determine the underlying cause of the neurological decline? Okay. So everything sounded perfect, right? But then the next morning he's lethargic, confused. The saturation, look at the saturation. It's 98% on 3 liters. No liver disease, no focal neurological deficits. Now, before I tell you the answer, let me walk you how a high scorer thinks, because the answer isn't obvious and the test writers designed this question specifically to trap you. First, let's talk about what's actually happening here. You already know that in a normal person, the trigger to breathe is carbon dioxide. Carbon dioxide rises, the brain detects it, you breathe. Simple. But this patient has COPD. Look at this thing right here. And here's the thing about COPD. These patients have been retaining carbon dioxide for years. Their carbon dioxide is chronically elevated, right? Chronically elevated, sitting at 50, 55, maybe 60 sometimes, So their brain, after years of seeing high carbon dioxide, they just stop caring. The central chemoreceptors adapt. They become desensitized. So now, the only thing that drives this man to breathe is low oxygen. We call this the hypoxic drive. His brain is basically saying, I gave up on carbon dioxide, so I watch oxygen. If the oxygen drops, I breathe. Are you with me? Okay. Now here's the thing where it gets dangerous. We put him on supplemental oxygen, his saturation jumped to 98%. And his brain said, oxygen is fine. Relax. No need to breathe hard. So his respiratory drive slowed down. But wait a minute. What about the carbon dioxide? Nobody told the carbon dioxide to stop, right? It kept building 60, 65, 70, 75. And at high enough levels, carbon dioxide crosses the blood-brain barrier and acts like an anesthetic. It literally puts the brain to sleep. That's why he's lethargic. That's the asterixis part here. Because of the metabolic poisoning, we didn't treat him. We accidentally sedated him with his own carbon dioxide. And the number that should have warned us is this one. This one right here. This one right here. It warned us, right? This one. 98% on 3 liter. It means we gave too much oxygen. The target in COPD is 88 to 92%. Not 98, not 100. 88 to 92%. We want them slightly hypoxic to keep that breathing drive alive. Okay, now rule out the options one by one. Let's destroy these options one by one and why each one is wrong and why a single one is correct here. Now here comes the most interesting part. Okay, brain imaging without contrast. I'm gonna tell you one thing about this brain imaging here. Wherever you see, it's not about this question. It's about every USMLE question. Wherever you see that focal neurological deficits are absent. You don't do CT scan, you don't do MRIs, because CT scan and MRI is basically to detect in order there is something in the brain or no. If there were something in the brain, you have to see the focal neurological deficits. So I'm not seeing any focal neurological deficits. And secondly, his extremities move equally to painful stimuli. He can move the right arm, he can move the left arm, the right leg, and the left leg, which means there is nothing in the brain causing his brain to shut down. There is nothing in the brain. Rule out this option. Now we have the urine screen for the illicit substances. Let me tell you something. The question here is, could drugs cause confusion? Sure, But this man is 68 years old, admitted to the hospital, being monitored overnight, and we have a perfect explanation sitting right in front of us. You don't go fishing for drugs when the answer is obvious. Just rule it out. Okay? He has been monitored overnight. He's used nothing. You're not gonna find anything in the urine. Now we have these three options, and I think the highest yield options: electrical activity mapping of the brain. Now, why is this? First of all, this is the wrong answer. And why is this the wrong answer? Let me tell you something. Are you gonna see anything in encephalopathy in the brain? Yes, you're gonna see something. What is it? It's the diffuse slowing. It doesn't show anything. It just show that there is something wrong with the brain. Why am I doing this investigation? Because I want to know the cause. If I don't know the cause, what's the point of electrical activity mapping? I already know that it's encephalopathy, and there must be something wrong in the brain. It does not tell me why. We need the cause, and the cause is carbon dioxide retention. Rule it out. Okay, the big mama comes here. These two options, D and E, the serum ammonia level and assessment of the blood pH and respiratory gases. Which one do you think is the correct answer, guys? And the correct answer is E. Now let me help you rule this big mama out. Serum ammonia level. And I want you to pay attention here, because this is where most students get trapped. Whenever we see asterixis, whenever we see this thing, our brain immediately jumps to the liver. We say, okay, it's hepatic NCAF. But okay, I'm not saying that hepatic NCAF does not cause it, but let me tell you something. This is the part 1 you want to remember. Asterixis is not owned by the liver. Yes, liver failure causes asterixis, but so does uremia. Liver failure, uremia, and the third thing here is carbon dioxide. When the carbon dioxide builds up, it narcotizes the brain and causes asterixis. So next time you see asterixis on an exam, do not automatically think it's liver. Ask yourself, is there a liver story here? Is there a kidney story here? Or is there a carbon dioxide story here? In this patient, there is no liver disease history, there is no kidney history, but a COPD patient who was just given too much oxygen. The asterixis is from the carbon dioxide narcosis. The test writers put this ammonia very intentionally in order to confuse you guys, and I'm gonna bet you that most of the students select this option because they only think that serum ammonia level, high serum ammonia level, is associated with this finding. No, but you have to look at the patterns. I told you multiple times, step 2 CK is not about knowledge, it's about recognizing the patterns. Okay, it's a very typical pattern of COPD patient who gets worse after getting oxygen, and a hell lot of oxygen, 98%. You never give 98% oxygen to a COPD patient. It's a deliberate trap, and now you will never fall for it again, inshallah. This is the ABG part. This is the ABG part. Why do we do it? Because it's going to show you, the ABGs are going to show you the respiratory gases, the arterial blood gases are going to show you. The pH is low, respiratory acidosis, carbon dioxide is sky high. Carbon dioxide is sky high. It's going to show you hypercapnia. Bicarbonate will be elevated. No other test gives you this much complete picture. The ABG is the only investigation that directly confirms narcosis. So here is the rule. Write this down. COPD patient, give oxygen. He's confused the next morning. SpO₂ suspiciously high. Asterixis present. No liver disease. That is carbon dioxide narcosis, buddies. And the answer is always ABGs. And remember, in COPD, again, I'm going to repeat it for you. The SpO₂ is 88 to 92%. That's your target, okay? Not 98, not 100. Because sometimes trying to help too much is exactly what hurts the patient. See you in the next one.